Thank you. My name is Carifelle-Brzezicki. I'm the interim manager for the Indigenous Health Program for Alberta Health Services. I want to acknowledge the people that I'm with, and these are just four of 30 staff that we have at AHS, and all of these people who came today are experts in their own right, experts in their own field, and contribute on a daily basis to the health of Indigenous people. So I want to acknowledge the people to my left. I am Métis. I was born on Peavine Métis settlement, a small little tiny community, very, very north. And in my community, we have approximately 500 people. And so I came to Edmonton a long time ago. I won't talk about any numbers, but I do want to say that I acknowledge both my grandparents, and I do have 10 grandchildren that are really, really important to me, and they're the reason why I do the work that I do every day. So apparently I have something that can click. Is that true? This one? Oh no, you need to know a couple things about me. And the first thing is, okay, there we are. Not everything works for me. These guys are all laughing already. So this is the four of us, and they will introduce themselves. And so really quickly, what I'm going to do is just talk about who we serve. I'll talk a little bit about the Indigenous Health Program, and Emil will talk about our cultural helpers. Natasha will talk about our clinic, and Wayne will talk about the future of Indigenous health. So who do we serve? And I know a lot of people who are here are very familiar with some of the stats that we have in relation to Indigenous people within the province of Alberta. And generally we're 6% of the population, and generally we're 6% of the population. And I'll just leave it at that, because I know many of us know some of the stats. And generally we're sicker than the non-Indigenous community. We deal with issues like arthritis, asthma, hypertension, mood disorders, and anxiety, and those areas greatly affect most of our community. And we have practices that really, really hurt us. But a lot of people don't realize that there's a trend within our community to actually get better and get well. So 30% of our community, 30% of our First Nations people, 25% of our Métis, and 25% of our Métis community actually just don't drink. And people generally just don't realize that. A lot of our stats, a lot of how people look at our community generally look at us from just areas of just not wellness, right? So how do we get here? So there's historical events that have led to where we are and who we are. Our friend talked about the arrival of new diseases and our community's inability to be able to deal with them. Contact with our non-Indigenous people actually caused a lot of upheaval within our community. So there's a lot of deaths, a lot of wars, a lot of just a lot of issues that dealt negatively within our community. And then of course there's the disappearance of traditional food sources within our community. And very often, we've heard about becoming words of the government. Policies like the Indian Act have really, really hurt our community. The outlawing of our cultural practices, and our cultural ceremonies. And very recently we've heard a lot about residential schools, the 60s scoop, and then other social practices that have really, really hurt us. Of course, residential schools, and I'm sure a lot of us in our community have really heard how that has impacted and hurt our community. And so we're just finding out now, long-term and medium-term, how this has affected our community. And this young boy is the same person on the left as he is on the right. So over the past about 10 years, there's been this whole emergence within our community to be able to look at how history has affected who we are as Indigenous community. And so within our community, we have now more Indigenous researchers, more Indigenous people who are looking at us and saying, hey, how did history affect who we are? And so we're hearing things like, and I'm sure it won't be any surprise to anybody in this room. So we hear issues of the barriers to healthcare are issues of systems, so some socioeconomic, some issues of discrimination, history, and cultural insensitivity. And I'm going to come back to that in just a while. So as the Indigenous, these are some people from the Indigenous Health Program. Some of us were in this picture. Here I am on the left. And these are people actually from our program. So we will talk about the clinic and our cultural helpers, but this is, you look across some of the people in our clinic or in our program, and you'll see that most of us are Indigenous. We have in there physicians, cultural helpers, clerks, nurses, and so I thought that this picture is really reflective of who we are and what we do. And if you actually apply for a job with Alberta Health Services, I think this picture is of pictures of us that they have on there. So who is the Indigenous Health Program? The Indigenous Health Program actually started about 22 years ago. We had an influx of money from Novacor. They actually donated $1 million to, at that time, the Royal Alec Hospital. And they said, here, do something in relation to Indigenous health. And at that time, we had a wisdom committee. And what we did was we had people who were from the First Nations or from the Métis and from the Inuit and from the very, very far north. And they got together and they said, okay, what do we want to do and how do we want to respond to Aboriginal health at that time? And so they got together and they said, well, we want to look at diabetes, and we'll talk about that a little bit later. But they also provided, the door actually opened for the Indigenous community to be able to say, hey, and begin to take control over what we wanted to do and how we wanted to look at Indigenous health. So in this committee were people from, okay, so from the entire length of the province, from the north to the south, but they actually got together and they said, hey, we find, at that time, they want us to look at the issue of diabetes. So 22 years ago, we started a diabetic wellness clinic. And it wasn't just a diabetic wellness clinic. We actually, and continue to provide services, continue to provide, sorry, I'm stepping over you, and I'm trying not to, and provide services, and I'll just leave it at that. So the mandate of our program is to be able to facilitate across AHS the development and delivery of essential services to meet the needs of the diverse Indigenous population of Alberta. Sorry, let me go back. At the Royal Alec, every year during National Aboriginal Day Week, we provide a certain open forum for people to be able to come and just learn more about our program, learn about our community. So that was actually from last year. So the program is guided by these principles, and really it's respecting and providing care that's done in a dignified manner and in a respectful manner, and we really focus on the uniqueness of everybody who comes in through the door. So as the Indigenous Health Program, very recently in 2012, we actually redeveloped a Wisdom Council. And what this council is 19 people across the province. And what they do is actually provide recommendations to the CEO of Alberta Health Services. And so this Wisdom Council, this group of 19 First Nations, Métis, and Inuit people actually provide recommendations to our CEO. And this is the structure of organization. So we have a province-wide Indigenous health program, and these are our core functions. And these are priority areas. So we looked at customized healthcare approaches, patient family-centered care, and we provide partnership and relationships development with the communities and education to our communities. This was an example of how we provide engagement to the hospitals, not so much the communities. This was done 2 years ago, and this is when the Royal Alec Hospital actually made the Guinness Book of World Records in hand washing. So we had, so the Indigenous Health Program was involved in that process, and so we have we provide as a program. We work really closely with the leadership at the hospital. So we sit at the leadership table, we sit at the operations table, and these are just pictures. This is a picture of one of the day that happened, and I think it just shows how well and how closely we work together with the hospital. So what we're going to do is is actually now talk about some of the cultural practices that we do as a program. And I just want to say that we've had the privilege and the honor of having the cultural practices, the issue. So we've been able to provide cultural practices within the Aboriginal Health Program in a really open manner. So we've gotten a lot of support from leadership, a lot of support from people within AHS to be able to provide the practices that Emil is going to be talking about. So I want to introduce Emil Durocher, and he will introduce himself. He'll give you more information about who he is. Is that okay? Yes, okay. I guess, he says. Thank you.
Well, good afternoon, everybody. It's good to be here, to see people in Banff again. I've lived my life about 35 years in Calgary. I'm from Edmonton. Family's from there. My dad was a Métis. My mother was First Nations. And but I grew up in every reserve you can think of in Alberta. And I've experienced a lot of things. And when I was asked to come to, back then it was Alberta. It wasn't Alberta Health Services. It was Capital Health, it's called. And my credentials, I don't have a PhD or any certificates in that nature. I was hired through a pipe ceremony. My credentials are pipe, the sweat lodge, and medicines, and the knowledge. And those are things that I was hired for at the first. And after when it became Alberta Health Services, I was asked to be a part of this group. And what I do is I do ceremonies, I do prayers for Alberta Health Services. And we, this is the first sweat lodge, I guess, that Alberta Health Services has had for the last 12 years. And a lot of people don't know that the sweat lodge is for them that work for Alberta Health Services. But it's been there for 12 years and it was functioning still today. And I still run the ceremonies. But a lot of things we go through as culture helpers. We have to select certain people for that. And usually we use traditional knowledge on how to be a traditional person. How humble are you? Humility, how much humility do you have in your life? Do you have to be dazzle people when you talk or present yourself? At one time, the elders had told me, quit showing off. Tone that down. You're a traditional man now. All those things you left behind. You have to be humble. The praise and all the leadership and all these other things will come, but it will come from the people, not you. You don't have to present yourself as that. People will tell and they will talk and they're the ones that will do that for you. That is none of your business. So that's what I did. And today, in our culture program, I sit with people that are getting interviewed and for culture helpers, because we need healthy mind, a healthy heart and body, and how you live your life. And recently I've pointed out a lot of things to Alberta Health Services, is that we are working for Alberta Health Service. So if you have prejudices or dislikes or racism, what are you doing working for Alberta Health Services? You're supposed to be healthy. And that's what means. And even if you're a culture helper, I was a culture helper for 10 years. I've never spoke to nobody. I looked after the elder and his medicines, and I looked after everything. I never spoke to anybody until I was told that I was ready. And today I still live the same way. I'm 64 years old now, and I followed this way over 35 years. And the elders still guide me today before I do something. And protocol is the most important thing. People a lot of times will look at an elder or a medicine man or a spiritual person. And these are all in society, they put them all together when actually they're not together. They're separate. They're not all the same. So you have to present certain things in a certain way. And usually tobacco, everybody frowns at tobacco, but that was our first medicine. And today, it's not, a lot of ingredients are put in it. It's like these medicines you see on this page. It's like all those ingredients were put together for the tobacco we use for the pipe. And that's why it was sacred. And that is what we present first. It doesn't mean that you're going to get help or an answer from that person. They have a choice. If they don't want to do anything or say anything, they'll push it back to you. But these are things that we have to also respect. And our ceremonies that we do is the first one is teepee raising, and we have our feast there also, and invite everybody to come be a part of that. And also there are other ceremonies that we have in the community itself. The round dances, the horse dance, the chicken dance. And there's a long list, and you'll see them here. And a lot of times, even names is a part of the ceremony, that you can't disgrace your name, and those teachings behind that also. And those are the things that we have to protect. Even the pipe ceremony itself. And the pipe ceremony is the most sacred thing, because it goes everywhere. And it's a first thing that we do in any ceremony or anything we do. And the directions. And a lot of people will see this and say medicine wheel. To us, as Cree people or Stony, we don't see it as a medicine wheel. It's a circle of life, you would call it, I guess, closest to. It's the way you live. When you add medicine, now you're saying it's something else. But that's how it was created. And the person that created this one was also one of my teachers. And now he had passed on now. And some of the people that come first, before me, were a big part of our culture in Indigenous health program. It took them to wake up a lot of things. There's a lot of obstacles that stood in their way. And it's today, what we do is still in its infancy, but it is growing. And a lot of people are starting to recognize certain things. And it's not only Alberta Health Services, but it's Indigenous people also that are starting to realize a lot of things. Because racism goes both ways. If you start feeling or seeing racism around you, and it's probably because you see that and you feel that within yourself. And once you make amends or deal with that, then you don't see racism. And you have no reason to even go there. And those are a part of the things that we do. And some of the things that I've worked with, I guess, with people that I've worked with. You've probably seen the dancer on the website there. His name is Wayne. He's having a battle within himself. This man here, he's a chicken dancer. He has a battle of life for himself also. He's done a lot of work. He's been here before also to speak at one time, but he's fighting for his life now, and we have a lot of our prayers are with him because we lost a lot of helpers in that way also. And today, with the helpers we have, I try to monitor them and try to help them as much as I can. And usually the sweat lodge will help to clear their minds and their bodies. Because when you're working with people, especially with infections, they need a lot of support, even the workers. Sometimes we get in that weak point, at weak time. That is when the infection will get us. And in our teachings, it's how do you fight infections? And the first thing that we were taught is strengthen your immune system. If you have a strong immune system, you can fight anything. And there are medicines that you could do that. And that means a healthy mind, a healthy heart, and a healthy body. But in doing so, you have to learn how to eat, what to eat. A long time ago in our traditional past, we've learned to eat certain foods for each season. We don't have apples or oranges or bananas because they're not from here in this country. So we eat what's around us. We have berries and all that. And there's reasons behind that. Those are medicine themselves, and they'll strengthen your immune system. In the fall, in the winter, we have certain foods that we eat. And although the animals now themselves are getting infected also, because they have to eat certain things. So they pass those on to us when we eat them. But, thank you for listening. It's good to talk to you. Thank you.
Hi, my name is Natasha. I'm the clinical team lead for the Indigenous Wellness Clinic. So one of the ways to improve access was to, in addition to the diabetes program, which I'll talk about as well, they've created an urban primary care clinic. So what we're located, we're located in Anderson Hall by the Royal Alexandra Hospital in Edmonton. We provide culturally appropriate and a safe environment for Indigenous people and their family to receive all kinds of services. When we first started, we actually had three physicians, a primary care physician and 2 endocrinologists, and we've, in September 2016, we expanded our practice to 8 physicians, and we now cover not only diabetes, but primary care. We have palliative care, women's health, and we've increased our mental health and addiction support. So we are a multidisciplinary, or we work as a multidisciplinary team to provide holistic help, or holistic care, and we've developed a bunch of groups. We provide resources and support, and we do screening and health promotion. We're family focused, and we're considerate of barriers. So some issues that come up because we serve a large population, not only in the Edmonton zone, but we also serve populations in northern Alberta, northern BC, Northwest Territories, and even we've had some patients from Nunavut come as well. So we're cognizant of barriers such as transportation issues. So we know people have to come a long way. We know there's price with it. And so we try and coordinate care as much as we can. We are considered a family dynamics, food insecurities, and we do work with a large homeless population as well. And so we want to improve, we want clients to feel comfortable and improve their health as much as possible. So we offer flexible rather than fixed appointments, and our appointment times are longer. Our physicians work under an ARP, which Wayne will go over. So most of our appointment times are minimum of 30 minutes. And we're not one of those offices that you can only talk about one problem, and it's not just you go in with, my diabetes is out of control, I'm suffering from depression. We're looking at the entire system. So what is causing it? Is it, you didn't have a place to sleep last night, I have nowhere to store my insulin, I haven't ate in 3 days. So we look at all of that rather than just, your blood sugars are 13.7, so we got to fix that. We have grown quite a bit over the past 2 years. So our stats from January 2015 to March 2016, we did have 3,700 completed appointments, and more people are coming back to us. We are very cognizant of, people who come in who may have been living on the streets. They're not as comfortable accessing care because they haven't showered in 2 weeks, or, maybe they are intoxicated and under the influence of drugs or alcohol. And we don't judge. We have no judgment whatsoever. People come in. They can always have coffee, water, and tea. If they haven't eaten, we look at getting them food. We look at making sure they have access to other services so it's not a continuous problem. If you don't have ID, you're still able to access care from us. And then we just look at different ways that people can connect with each other and with the staff. So by having the different groups, we do different activities. So from crafting to making hygiene kits, to gardening. We actually have a patio where we plant food in different vegetables and flowers, different herbs, and we plant them in May, and then in September we have a harvest, and we have, we'll make some kind of food depending on what kind of stuff worked for us that year. Last year we actually grew 2 pumpkins we were very excited about. And we look at, and then when we're looking at the family system as well, we're looking at, people don't have access to childcare, so they can bring their children in, and we've actually developed what we call a Cook'em's Corner, where kids will come in, and while their parents or their other siblings are accessing care, we provide different crafts or different books for them to read or different games. And then in keeping with AHS infection prevention policies and stuff, like they're single use, they always go home with it, everything is wipeable, stuff like that. So we still offer a 4-day holistic and cultural diabetes program for people with diabetes. So people will come and stay with us for 4 days in our building, and they learn all about their diabetes through a multidisciplinary team. So we look at, so they'll see the dietitian, they'll see nursing, they'll see an endocrinologist, they'll work with the cultural helpers, and we respect the use of traditional practice in addition to Western medicine. We assist individuals learning how to balance their minds, body, spirit, and emotion. And we offer it 1 week per month. It originally was a 1 or 3 day basic education, and then we've expanded it to 4 days. And then we also offer community outreach on diabetes awareness. We don't go to community anymore, but we still, when people come in, we provide services for them to bring back to their communities. And so full medical assessments, multidisciplinary education sessions, daily activities. So from any kind of physical activities, we offer retinal photography. And this is an example of some patients who were learning label reading. And our program is interesting and kind of inclusive because you can see specialists, but you don't need a physician referral to come to our program. So anyone can refer to our program, including family or individuals. Like I said, clients come from all over Alberta. In Edmonton zone, last year we saw 284 clients and their supports. And we also encourage healthcare professionals to come and learn from the patient perspective rather than just going to a class and learning about diabetes and stuff. You get to learn as a patient, and you go through the sharing circle and you learn different experiences, and we feel it's quite valuable to healthcare professionals. So one of my other jobs was to guide the program through accreditation last year. So we did receive 100% on the Aboriginal Integrated Primary Care Standards that were set by Accreditation Canada. It was the first time that we went through it in Alberta Health Services, and there was a strong emphasis on client and family input on setting the standards. So in addition to the required organizational practices that were related to patient safety, they also had high priority standards that were criteria related to safety, ethics, risk management, and quality improvement. So we worked with the different teams within Alberta Health Services and within the policies set forth to ensure that we were providing the best care without impacting any quality of care. So we consulted with infection prevention and control. Whenever we implement a new program into our services, whether it be women's health, we have an ultrasound machine, foot care, anything like that, we always consult with IPC and MDRD to ensure that our standards are being met, and we're not purchasing equipment that can't be used. We do regular audits. In addition to, we encourage hand hygiene, we do patient education, especially having a high population of homelessness in inner city. We look at ways to minimize exposure, harm reduction standards, and basically, and even providing stuff for patients, like I mentioned earlier, hand hygiene kit, or hygiene kits in general. Ways to improve food safety, and then annual continuing education of our staff as well. In addition, antimicrobial stewardship we also do. So we do take a multidisciplinary approach in all our work that we do in the clinic. And some other client testimonials are just up here regarding our program. We do have a suggestion box as well that people can recommend. Well, to be honest, when we first got it, it was mostly about stuff that I implemented because people didn't like some of the changes. But patients are actually now starting to put suggestions into it about ways that, what they'd like to learn more, what they'd like to see in the clinic. And so every suggestion that comes through, every evaluation that comes through, we personally read and we make changes based on that. So it's very important that it's not just, because Alberta Health Services is a provincial body and we do need to maintain the standards set forth by them, we also want valuable input from our clients and their families to ensure that we continue to focus on them in addition. So I will invite Wayne up.
Never had a problem with a mic, so. Good afternoon, everybody. It's a pleasure to be here.
We need the mic for the webcast.
Oh, sorry. Okay, just watch the volume. Thank you for being here. It's a pleasure presenting with my co-workers. And so I'm here to talk about the future. We talked a little bit about the history, the culture, our clinic, and the fact that we got 100% on accreditation. And we as Indigenous people can run healthcare as well as anybody. We've proved it. And that's part of what I'm here to say. And I think we heard that in our first presentation as well. So as far as our clinic, This here is actually a picture out of Fort Chip. This is their health center. So northern Alberta, very northern Alberta, almost to the Northwest Territories. Winter road, no road in summer. So you got to get there by river or fly. And of course, this is in the middle of winter. So that just rural and remoteness, we still deal with that, probably like Northern Ontario. And we have some very remote communities. So of course, we're challenged by delivering healthcare to them. As far as our program, you know, we want to grow and we need to grow. We want to expand primary care, and we've heard about that. So our future, of course, we need resources. We're moving from just diabetes to primary care at the Royal Alexandra Hospital, but we want to go beyond that. We want to go into our communities. We have 43 reserves in Alberta, First Nations Reserve. We have 8 Métis settlements, and our intent is to move primary care into these communities as well. A lot of these have health centers, and the intent is not to tell them what to do or force them. We work with community, and it's only at whatever community decides is the pace at which we work. So just so that's clear. As far as funding, we're very fortunate. We have what they call an ARP. It's basically an alternate relationship plan. It pays physicians to work in community. So we get money from Alberta Health, which is our provincial government. Right now we have an agreement till 2022 or 21, and so it's been renewed. And this is to pay physicians to go work in community. You don't get paid if you're not in community, and that's the whole idea, right? We have in the agreement we have 19.27 FTEs, about 7.1 million. We're at within there we have 15. GPs, roughly, I mean, when you divide up the FTEs, we have the 2 OBGYNs, 1 psychiatrist, and 1.1 pediatrics. So those 19 have been, they started out as GPs, and we went to Alberta Health and said, this isn't working for us. We need some specialists in here. And so we've negotiated with them, and they haven't raised our agreement, but we've prorated some of the FTEs, just, you know, based on the salary, right? And of course, this is an opportunity for physicians who, the one good thing about this work too is I work with Dr. Ellen Toss, she's our lead, and it's not for everybody, this work, physicians, but we do, there are physicians who want to work with our people. And so that is very encouraging. Target population, of course, is Indigenous peoples throughout the province, so we cover the entire province. Clinic-based primary care services, also, so moving beyond or covering off chronic disease, chronic pain, palliative care, mental health, and so on. These are all within our agreement, so our physicians can work with patients or clients, what have you, and spend the time that it takes or that they need to. This second bullet here, the way the agreement was written actually was on an, you know, Alberta Health, of course, they always need to start with a model, right? So we started with an 8-hour day, 7 hours of appointments. Each appointment is 30 minutes. So, and that was to deal with the complexities of our people. They might come in for a certain acuteness, but we need to take the time, physicians need to take the time to get beyond get to the root causes and move past the acuteness of why they're there. So we feel this agreement, you know, the idea here is this agreement allows us to do this. So this is just a guideline. Some days you have 3 walk-ins that are first-timers. You might see 6 people that day, whereas other days, you might see 15 or 16, right? So this is just a guideline, but we are allowed to spend time. That's the whole idea of the ARP. So we're located in First Nations and Métis settlements. Some of the benefits, I'm going to skip over some of this just for the sake of time. Expand to primary health care, so diabetes wellness clinic. So we're going to a primary health care model. That's at the Royal Alexandra Hospital. So some of the physical changes that we went through in this change, we have 3 new exam rooms, spiritual, cultural care room. We are able to smudge our ventilation system. We had to work on that. I'm sure a lot of you are aware of that, whether it's a policy to actually burn substances or properly ventilate the building, so on. So we've worked through some of that stuff. We have policies in place. We have rooms for individual counseling, space for physicians, of course, and nursing support. So we have grown. Accommodations, we do, like Natasha said, we're actually very fortunate. We have an old nursing residence that we work out of. The downside is we don't have AC, and of course we just had a heat wave. So our clinic can be like 80 degrees during the day, and Natasha's just cringing over there because I was called down last week because that was the emergency. But we're very fortunate. We have room to actually have patients. We take them in, or they can stay at our facility and take the diabetes training. So we're very fortunate there. And we provide, there's meals and transportation. Of course, we work with non-insured health benefits. That's the feds, of course. Aids to daily living, that's the provincial support network in Alberta for that. Taxi vouchers, City of Edmonton bus tickets. These are all the things that we have found our people need and that we provide. Obviously, a lot of things are discretionary. We just don't hand these things out because we're on a budget like everybody else, but we will do that for our patients when needed. As far as our expansion, 2014, we had 2 physicians. This is in the clinic, 1.3 FTEs, 1 GP, and 1 specialist. May 2018, we now have 6 physicians, 3.38 FTEs, 4 GPs, and these GPs, of course, have specialty areas, which is great. So we've got diabetes, palliative care. Our palliative care doctor does home care, actually sees patients we're located in the inner city. Some of her patients she will see where they reside. So if that's on the street, that's where she goes. So we're very fortunate. We have, of course, women and addictions and mental health, and then we have 2 specialists. We actually have 2 endocrinologists. We're quite fortunate there. Allied Health Services, 2 RNs, 1 physiotherapist, dietitian, community health rep. She's our food, shelter, clothing person. She's so wonderful. When you need, well, I guess in some ways she's a social worker, but we see her as much more than that. But that's what she finds for our patients, all of those types of things. Mental health worker, senior cultural helper lead, and we have 2 clerks. So those are the staff that help run our clinic. We're looking at adding a pharmacist, really to do a part of our rounds. Our idea is maybe we can borrow one from the U of A if anybody has some interest, but we need to, we can't fund everything, so maybe some sweat equity. Sometimes universities will have an interest in supporting Indigenous people and will lend their services, or, they will, this is an area that they just have a real interest in. We talked about traveling out, so these are some ideas. So we'd like to travel out to more of the communities, of course, 2 to 3 times a year. We have only a certain amount of capacity, but the idea of traveling out and providing a 3-day diabetic program or even a 1-day program out in community, and more telehealth and possibly home visits. So this is how we want to grow as a clinic. Primary care provincially, we have 31 physicians in that ARP agreement I was telling you about, 23 general practitioners, 8 specialists. You can see they're up here. And currently we're using 9.82 FTEs out of our 19.27. So, and we're expecting to use the remaining FTEs by the end of the year. Dr. Ellen Toth, our lead, she generally recruits, I support roughly. And we've actually been making some really good gains lately with some of our primary care networks. So basically, they include a lot of the Indigenous communities within their areas, but they actually don't provide any services to them. So we're speaking to some, and they want to start going to the community, which is great. Primary care provincially, so we have 3 urban sites. The Indigenous Wellness Clinic, that's the clinic at the Royal Alexandra Hospital. Poundmakers Lodge, that's actually an independent service provider, but physicians do go work there. Our physicians go work there. And then we have Elbow River Healing Lodge in Calgary. And then we have 11 First Nations Health Center, health stations. So I said we have 43 reserves. We're in 11 of them. So we need to get to the others. And these are some of the places that we're at. You might recognize some of these. In fact, Stony Health Center, we have one of our docs is from Canmore and goes out to Stony. We actually have more than one there. But of course, we want to work with, we have the Métis Nation of Alberta in this province. They represent off-settlement Métis, and then we have our 8 Métis settlements in the north. And so we want to do more work with them. We've actually talked to both of them. And express the support we can provide, and we're in continued talks with each of those organizations. I used to work, we've actually 2 of the panel members here have worked for both of those organizations. And that's pretty well it for our presentation. So there's our website up there if anybody's interested. But thank you very much, and of course we're open for questions.
So we do have a few minutes for questions, so if anyone has a question or comment they would like to share, please do come to the mic. Thank you.
Hi, I'd like to thank you all for your presentation. It was very informative. Coming from an area that has not really flourished in Indigenous health, if I were to come to work to an area like Alberta, because I did quite a few years ago, and I worked in an acute care facility, do you have any educational programs from people who don't have a huge knowledge base about the nuances with Indigenous health, the smudging, the sweat lodge, those types of things, so that in an acute care facility, when I'm working with people of Indigenous, that I understand the holistic care? And I think that was a gap in the late or early 2000s. I'm just wondering, is it still a gap, or do you have something in your program that can bridge people? Because you're talking wellness clinics and you're out in the community, but Indigenous people end up in hospital as well. And there's a real, it burned me out dealing with the challenges. And I think that's just unfortunate, and I was just wondering if you're able to make any headways there.
That's a very good question. We do have, and my panel members will have to help me out here, but we have annual, it just became compulsory. So we have annual compulsory education in cultural competency training. So we've developed that training. Other individuals that work with us in the program have developed some training. It's been running for 2 or 3 years, Carol?
Yeah.
Yeah, and of course we pushed to get it compulsory because we felt that was the best way to do it. And so we now have that available to staff. And just recently it became compulsory. So of course we're quite happy about that.
Awesome.
Just last week.
Awesome for you.
And
I-
Emil also said too, Emil offers sweats to, and I don't know if you got that, but he offers them to the patients, but he also, there's staff days where I can go, anybody can go, obviously they need a day off, but Emil offers those sweats to our staff, and anybody can go. Unfortunately, we don't necessarily have that across the province, but, and then recently even, it's funny because with the government having more interest, let's just say, we've had some government staff come by and Emil's provided a sweat for them, so to learn and teach and so on. And if Carol, want to add anything?
Sure. I think the only piece that I will add is a good example is in this territory, there was a racial issue in relation to a blood tribe member. And the CEO of AHS, who we work for, immediately dealt with the issue. And the issue happened on a Friday, and those 2 staff members were not working on that Monday. So from the very top level of our organization to to the work that we do on the ground, there's an issue of Indigenous health Indigenous people being really important at all levels. And so that, I think, was really reflective of how important AHS feels the issue of Indigenous wellness, Indigenous health, Indigenous people are to this province.
Yeah, because
So it's a huge shift.
You have a huge mix of people who aren't from here and may not have the exposure of the Indigenous health and their cultures, and it's really important. And I know in Newfoundland, we're starting a new hospital where I live, and part of it is they're meeting with the newly formed tribe, or the council, and they are having a smudging area, and they are having a sweat. So it would be really great if we could communicate with you guys to find out a little bit about that education, because I know I've never been exposed to it,
So
right? And as a nurse working in acute care, I'm going to need to understand it.
Alberta Health Services does have a YouTube channel that provides a lot of, I think there's 34 videos for Indigenous health that provides there's some of the same content as our compulsory education for staff that is available to non-AHS staff. There's also the University of Alberta has a course that is available to anybody. People can take it for free, for credit, or for a fee just to get a certificate as well. And that's on the University of Alberta website.
Thank you so much.
And I just want to highlight, when I spoke about the Wisdom Council, that they are advisors to the CEO. And I think, and that's the only, like, we have health advisory councils, but the Wisdom Council are direct advisors to our CEO. So I think having that advisory level at that level also impacts how service is provided on the ground. Thank you for your question.
Thank you. Any further questions, comments?
Just one briefly, I just want to say well done, you guys. That's amazing work that you're doing, and I want to continue to encourage you to move forward here in Alberta, because you know that, like, from your stats there, the numbers don't align for access, and you guys know that, and I think the people in the room need to realize that. Like, if you're only seeing 3,700 people and you have $7 million with your FTEs, there's a lot of work that needs to be done. And so well done, you guys. I think the room needs to give you applause for that, because that's an amazing feat that you're doing with the expansion. So well done. So briefly, because I know we have another speaker, I'm really interested in Natalie, right? Natasha, sorry. I'm really interested from a clinical perspective, how are you ensuring that we don't duplicate colonial checklists or colonial regulations in this accreditation monster that's not contextual to emos and our ancestors' traditional beliefs of quality? So if you can answer that, we'll talk later over coffee if you can't, because I'm really interested in what you're doing.
So it is, I think working in our multidisciplinary team, working with the cultural helpers, taking input from the Wisdom Council, but still at the same time ensuring standards are being met from Alberta Health Services standpoint. I think just working throughout it, we ensure that it's not necessarily that checklists are being made. We do look at how it could benefit patients and families, both like in Edmonton and in the northern communities, by just implementing some practices. Roger, you made an example about how your kids didn't know to, take the paper towel. Just ensuring stuff like that. Sometimes it's questions, but mostly it's just, as of right now, because it's still kind of baby stages for that, is minimizing exposure is our biggest harm reduction. And then slowly building that up to increase capacity and how people can implement it. And then also, because we're a provincial entity, and then our First Nations communities are a federal entity, bridging that gap. I always, like working in previous jobs and stuff, I always made jokes about if I was asked to go into community, if they lift up the red tape, I'll climb under it. Just so we're looking at actual improving Indigenous health for people and not just looking at red tape and stuff like that, or just clicking off everything on our standards and stuff like that. So how do we, working with the communities and health professionals to ensure that it's being done.
Yeah, thanks. I think it comes down to the same message that we heard from the first speaker, that it really is working with the community as equal partners and asking what works for them, right? It really is important. Emil.
Yeah, I'm just going to answer a little bit on what he was asking about. I know it's it's really important for Alberta Health Services, the stats. You have to do documentation and all this. In our traditional ways, we frown on that. So we have to develop something to protect the medicines and the teachings and the people that are doing this also, before we could share that with them on paper. But the thing is that they have to do the writing, because we can't. So the only way you could do that is what one of the ladies was asking, is if you want to learn about the traditional ceremonies and all these other things, be a part of the ceremony, because that's how you will learn, is hands-on. And once you do that, you will never forget. It'll always be with you. And it'll be your teaching, and not others, because it's your own experience. That's what those ceremonies are set up to be.
Yeah, thank you, Emil. Are there any comments from the webcast, Lola? Any comments or questions? No, thank you.
We do have brochures and contact information. Will be
Perfect. There's brochures and contact information. I'm going to take the minute to say thank you very much to Carol and Emil and Wayne and Natasha. Very informative. Thank you very much.